know these guidelines because these will get you keep you out of trouble. So between implant and tooth, no more than 2 millimeters. I always shoot for, and in your kit, when we go to do this next segment this afternoon, I want everyone to start measuring. So in your kit, that measure, it's in the second layer. On the second layer is this gadget here. So you can easily measure with these. You measure whatever distance and you can lock it down. So measuring between you know, and see how good it is if with your digital x-rays. Measure across distal mesally on your digital x-ray, then go to the mouth with this and see if you're in the same ballpark.
Yeah.
Okay? So when we start to go off from the distal of like a bicuspid, it's number 19 there, and you see there's not an 18. If we go off of there and we say we want it to be 2 millimeters, and we're thinking about putting a 6 millimeter implant in place, then Martin, what do you think, how much do I really need to be off of the distal of number 20? Yeah, easily, huh? Minimal, because you have to think about the middle of the implant, the 6 millimeter, that's 3 plus 2. So I even shoot for 6 actually, because as you start to do your osteotomies, Jeremy, you're going to find that you are going to cheat closer to that bicuspid. And the worst thing that you can see there, Ryan, is that when you go to put your guide pin in, you're like, oh man, I'm 2 millimeters away, and I've only got like a 2.5 millimeter hole here. Because that hole's going to get bigger, isn't it?
Yep.
That makes sense? So it's a matter of safety. Just play it a little safe. And if we know we're going to go with a 6 millimeter, which we are going to do this afternoon, I want you to plan on being 5 to 6 millimeters away from that tooth. Now, if we have 2 adjacent teeth, like on number 5 there, most of you, I think, did pretty good. And if we took x-rays, we could really see, right? Yet 2 millimeters is about minimum. Some of these places, you're going to have to really shoot the slot here. And that's where you have to be steady hand. James can't have 3 lattes in the morning, okay? So it's a very important, Hassan, because you don't want to be tagging the other tooth. Now, between implant and implant, it's the same kind of idea. I always goal set for 3. And again, it comes down to which size is the implant that you're going to be placing. Now, the other thing you got to think about, where's Ross? Is he still eating?
He's hiding.
Oh, there he is. Now think about from Ross's standpoint. I always think his little head's in there. Now don't get him too close because you can't get the impression. Because when we put these impression posts on, Dale, if they're too tight together, then you're going to have to do a different type of impression, and that will be an open tray. Because if we are hoping in this scenario here to take adjacent impressions of 18, 19, let's say, and they're about 3-4 millimeters apart, then the material of the impression material will not tear when you take it off. Because one of the things that, if you're thinking about splinting those two together, that you can't have any distortion. And you won't know, right, until you go to try it on. So, if you feel like you're too close, then the recommendation will be an open tray technique. Take it out, make a window through the tray, and then unscrew it so that it stays locked in there. It doesn't come out and he has to pop it back in. I mean, would you agree on these? I mean, you see those tears and you're not sure.
Yeah, if you're really close to neighboring teeth too, it can distort your contacts as well.
Exactly.
And then on the open tray style, the implant body itself never comes out of the wash. You release the screw from the back side of the tray, and then your tray picks up the body aspect of the transfer.
Well,
So it's these little things we got to think about. Think about from his perspective, because last thing I want is him calling me. Unless it's for some like fishing or something, that's okay. But, you know, so that think from the perspective of the technician. What's going on through their mind and how they're trying to put this all together. Okay, so 7 millimeters vertical height from platform of implant to the occlusal plane. Remember the picture we saw earlier, Andrew? That guy's occlusion was really down and he busted off the canine. How many you get those cases come in? And guess what, Amy, right? It was attached to a bridge that it finally failed, right? Yeah. And they want implants there, and you're like, well, I gotta open the bite to do that. Oh, I had this bridge for 20 years. Why can't you just do the same bridge?
Because you have the same
I always love saying that. Oh, you want another bridge like the one that just failed? Because now it's too late. We can't do that. So 7 millimeters is a good guideline. Okay. 1 millimeter bone thickness buccolingual. Who was asking me about that? About the thickness, buccolingual. Okay, David. There. All right. This is really important. And so when we look at this, actually tomorrow when we're doing the immediate extractions and placement of the implant, it's going to be critical that we maintain the facial or buccal plates and stay away from, you know, the thinning of that in the front. So this is a minimum. And sometimes when you don't know how thick these ridges are, you're not going to have an idea unless you do open and flap and see it. Or if you have 3D, you could see it. Then you go, okay, well, I don't have the thickness there. And then what do? Can we go in and thicken it, right? Do a lateral ridge augmentation? Go in and plane it down, maybe? There's a lot of different little techniques on this. And then last one, 5 millimeter ideal height from crest of the bone to the bottom of the contact point. That's more for creating interdental papilla points. So we don't have gingival black triangles. Okay. The other one that's not on here that I think, and we've talked about it, a zone that is good to stay away from, all right, for me is the IA, all right, the inferior alveolar nerve, and staying at least, I try to keep 1 millimeter. Okay. I was talking to one, I think it was David back there, but my sister from New York flew out. She had number 18 that was failed, took it out, did immediate, and you'll go through this, Greg, and you'll feel it. And by the way, on the lowers, you won't necessarily feel it here. Yet, some of you who've been doing this long, you've noticed this on the lowers. You'll go through the cortical plate, and it'll go, all of a sudden it'll free fall. You'll go,
holy shit.
And you'll go, you just go in the nerve, and the patient, I'm fine. What do you think just happened, Philip? Yes. Where's my newbie, Bron?
Yes, sir.
Remember that? That's a board question.
Staphney's bone defect.
Yeah! You remember. Good boy. Staphney's bone defect. Okay? Those are just big trabeculate in air spaces, and you'll free fall. And you have to remember that, because that's the reason for you not pushing so hard. I want you to let that thing spin its way down, and some of you have come around and used the two-hand technique. You kind of feel it go down, and it'll chunk down. And you go, I know on my x-ray, IA is not for until 13. And I'm only at 10, and I go, poof, poof. So beware of these things. These are things that you will encounter. But stay about a millimeter shy of that if you can. All right, Bill, any other safety points?
Remember that the intraalveolar nerve is encapsulated in the cortical bone, so you're gonna feel it before you go in there. It's maybe a thin layer of cortical bone, but it's cortical bone.
Okay, so let's go through the video here. Look at your monitors. We're going to go through the process of showing the impression. already have it uncovered. You have in front of you the models, and they've already got the healing abutment on them. Go look for your transfer, the green transfer fixture. We're going to use that, and it shows there putting in cotton pellet. That's an easy thing to do, Andrew. But you know what? I've been using red rope wax to cover that, and the reason for that is that little pellet. It comes out a lot of times in the impression, and either you leave it in and let Ross take it out, or you take it out, but it leaves all the fibers and everything in there, and there's just that little, sometimes play of distortion with that. So I use the red rope wax. I really simple. I'll show you the actual technique, but in your, let's see here. Bill, if we need to, we can give them a little bit. I think they don't have it. But it's in that little tub right there. We'll come by and give you a little pinch of it. Just give them a little pinch of it. Okay. Is it bottom drawer? Look in your bottom drawers. Good boy, Nick. It's in a tub. There you go. All you need is a little pinch of it. So you're going to do this twice here. So let's get out a little, no more than like a quarter of an inch of it.
They put it in the thing for a pickle. It smells like the acrylic is spilled. You figure out how to actually get that open? Nothing like denture acrylic.
Find it? Why it smells acrylic.
Grab yourself.
No, light a match. Okay, got it.
There's your
Everyone's
drawer.
good?
Sorry. We're going to charge you extra
Okay.
for using too much rope wax. It's expensive stuff. Okay.
When I was in the Navy, we had the Navy supplied us some of these.
Yeah.
It was the older one, but there's like super big. They're like gold or so heavy.
You mean like this?
No, they were wider than that.
Oh, really? Oh, that was my old oroscopics.
Yeah, those are so heavy.
I had cervical neck surgery, and so these supposedly give you a better
everyone has
angle.
that?
So
Just a little quick thing here on your monitor.
it's one of these, right?
On there, you'll
Yeah.
see, if you really look hard there, Jeremy,
The Calcitech one
I've
is
shown this one before, but
come loose.
let's see, Greg maybe hasn't seen this next year. Greg, do you see a number of different type of implants there? Yeah. Now, interesting, in the one in between, on the bridge there, those are IMZs. Remember I showed those earlier? Now, the middle one, does that look like it's open to you, Kay?
Yep.
Margin, like there's no abutment, but there's a screw there?
Yeah.
Everyone see that? That's that plastic piece that was the intramobile element that we used to use. That's what it looked like on X-ray. Now look at to the far right. Do you see a ghost-like type of implant there? That's called a crystal sapphire. That's that my predecessor used to put those in, and they were immediate loads. The only problem with it was that if it broke at the neck, it was done. You had to find it out. So that's a little history there. But this is why we like the digital radiography. John, you just got a new digital, didn't you?
Yep.
You liking it?
Yes.
Finding some stuff?
Yes.
Yeah, it's like, how did I ever do it with film? So we can measure the depth, the width. I want you to use your calipers this afternoon when we get back into placement. And we can also look at density on these types of. So a couple of things about now how to enter. We talked about it earlier. There's a laser punch technique. This is something we show at the over-the-shoulder implant course. And take note of the number 5, I think that's 12 area. Look how broad that ridge is. You can see how broad it is, and you can go in, like Bill was saying, and actually map the, and a lot of times on these, I'll go in here, I'll open that area up, and then I'll take my probe and map, and find where it starts to dip off or run off on the buccal or on the lingual. Yeah, these are your great sites to do your first case. Okay, you've got the other flap, and you've got the punch technique. You know, the thing I saw Bill out on the floor, maybe John can say that too, is that I didn't see you release enough of your flap, doctors. You need to release more, because you probably found that it was tough to reflect and keep it open as you were drilling. Okay? And this is basically so you can check out the topography of the bone. Where's the deficiencies? And are you going to need to do anything additional, like closures with the membrane to help the site? Good suturing techniques. Going to be real important. So now we're getting to that point where the patient has come back, and we're going to do a number 8 this afternoon. And you have to be prepared here. You have to be, realize that they may not be happy with just running around with a gap there. So failed endos or a fracture the patient just came in with, can you put the tooth back? So there's a lot of little methods I'm going to show. One is if you have the time advance and you can plan for it, yeah, they can have a removable acrylic partial here, flipper. You can take the old tooth and actually bond it right back across. I've done that many times because they came in, they busted it right off. I look at it, it's failed, it's a failed shattered endo, take the tooth out, go ahead and put the implant in, and then bond across and bury the implant. If the primary stability is good enough, we can go ahead and load that and with a temporary crown, and we're going to do that on this one this afternoon. And remember, with the idea that the patient's instructed, Andrew, that they can't bite with it. They can't bite with it, and doctors, you've got to have this thing totally out of their occlusion scheme, their occlusal scheme, all right? And their CO, their lateral and protrusive movements have to totally clear. And that means that tooth is going to be a little shorter looking, and let the patient pre-frame them that it's okay. All right, Jeremy, it's okay. As long as you tell them, they will be okay with that. All right? And I've also used their old crowns and taken their old crown to do that and see results like this too. So, and in the posterior, I really don't do anything with that, Tristan. I just let it be and letting the patient know that it's going to have to stay like that. Okay? So it's just about being prepared. So let's get prepared.
Hey Mom, Dad, what's going on? All right, this is it. I'd like to introduce you to the newest member of our family.
Ah.
Hey,
Sorry, I was watching it.
Jerry. He's my new pug. He's a really good boy.
Urinate on you.
Oh my gosh. Oh my God.
That's what's going to happen sometimes in there, so we have to be ready for it. So.
He's a good boy.
Oh my God.
Probably broke a leg or something.
All right, so let's get my digital. Okay, so in front of you, you have restorative models. Get those done, and let me see if I can switch here back. There we go. Okay, so let's start with the upper arch number 5 that we had this morning. You had placed the healing cap on there.
Yep.
So in your kit, you have, this is always the screwdriver that takes out the healing caps, also the transfer copings. So we're going to go ahead and just unscrew this one here. And I tell you, a lot of times what you're going to see here is just a really beautiful tissue looking down in here. And sometimes down in here, you'll see some bleeding start. And who can tell me why there's bleeding? If it looked healthy, you took it out, James. You start seeing bleeding. Why did it start bleeding?
Hemodesmosomes.
What did you say, Jeremy? Sharpie fibers. So that means, Andrew, we've actually had adhesions established to just the healing cap. Okay, that's pretty cool. So that led us to believe that, wow, the least amount of times we have to disturb this area, the better, right? That would be ideal. So that's a good thing that we can get that. Now everyone grab now the green. This is your green transfer picture. And this will now orientate. And the beauty about this system, and I know that with the other one, Ankylose, this was a problem for me, because I don't know if any of you did anyone here have any of your crowns rotate on you? Like it's attached to the abutment, but it rotated, like 45 degrees, and it got wedged. You're like, well, how did that happen? Okay, so anti-rotational. So that's another thing I want, because in the posterior, you're getting a tremendous amount of PSI. So I want anti-rotational. So what you'll see on these is that there's a hex here, and there's then a slight taper, and you'll find that this thing will fit right in there. So a lot of times I'll just take this directly to the mouth and snap it in. You'll feel it all snap it in. So everyone go ahead and do that. Take your fixture screw and tighten this down. And give it a nice turn. Okay? Now, the red rope wax I had out, oh, I think it's over here. Let's just get a little pinch of it. So my assistants will have like that much out on one, and it's just a little piece. Okay? Take that and just take it, push it down on there, and just wipe it off. Okay? And there you go. That's done. Because when you go to take the impression, you're not catching this. It's not pushing it, catching the fibers, pushing the cotton, pledging in further, and then you get a little extension of the impression material down in here. That's where it gets a little crazy for Ross to try to reorientate that. And a lot of times he's down inside clipping that. I don't want him doing that. I want to keep it clean. Okay, everyone's got then in front of them, you also have your impression guns, okay, all in front of you. And the trays, are they out, Nick?
Yeah, the impression trays are in the third drawer down.
Third drawer down?
Yes, sir.
Third drawer down. On what side? Left side. And I know this is pretty white belt stuff. Yeah, like we do have some white belts, and we just want to go through this part. Yet this is, to me, the simplicity of this system. It is so easy. This just goes clicks down, I put it across. In fact, I love these days, John. I mean, I got scheduled maybe a half hour, you know, and that's a good charge out there, isn't it? You're plucking the fruit at that time. Okay? So we get the tray.
Got some impression
Okay.
material.
Everyone's got their tray. Now, like I said, if we had multiples like this and they were close, 1, 2, and 3, yeah, you got to make sure the spacing is good enough here, that the spacing is good enough so that you don't have thinness between the abutments. In which case, you may want to open up a window here and unscrew those. Okay? So let's go ahead, everyone get that, and I want you to just go through the process, taking the impression. All right? Yeah, I tell you, it's the day you deliver. So today is for success. Get the beautiful impression so that Ross makes us a beautiful abutment and coping and TFM or whatever crown you want, and it just goes in click, click, click. Yeah, just use the one phase model phase since we don't have the little mixing tips. But I do use, in my practice, I do use the Impercum system because the poly ether is much more rigid. And I use the wash first and then the heavy body on top. And that's pretty rigid. It's pretty rigid. You got to pull pretty hard to get it off. Okay, yeah, you got the machine here. These trays, you know, I'm not, is it 3M? Yeah, you see the lock-in
You
here.
know, they were talking about splitting them on the light. I was.
Hey Nick, who makes these trays?
3M?
3M?
Sometimes the night, the framework and it's just a little bit off, and you have those implants in there. It's just like a bridge. You bite down the cotton.
Oh, no, they got nice lock-in. If you look at these trays, they have a nice lock-in of how I've never used them. I use those border locks. Multiple border locks.
Which is supposedly the leaf shrinking and all that kind of stuff. And you know, I've been in class and they wrap the cloth around it to give it a.
Yeah. So
But
3M.
you know, I had a case 15 years ago where we were trying to hang on to a precision attachment.
Okay, so yeah, now, what was the set time on this material here? Is it 5 minutes?
And then when we split it together like that, compression.
Yeah. A lot of the materials are a 4-minute set. On the Impergum Quick, it's a 4-minute set. And like John was taking, the point was well taken. I let it go another 30 seconds. I just want that to be really, really set. So when you pull this off, you try not to pull it at an angle. Try not to pull it like this, but to come straight down with it. So you really have to grip it from both sides to come down on it. That way you can pull it where you see that you're not going to be stretching it across here. There's been times though I've had to take a disc here and actually disc this. Make it thinner through here, just disc this a little bit, or here. Sometimes it's going to be really tight, and you can do that. Just leave enough of this other undercut here to orientate the transfer post into the impression, but you can disc this flat, you can disc this flat. Gain yourself some more room on that.
Who can tell me something about Zimmer parts here right now? The button we're using right now, that comes with the implant, right? That's kind of the thing we kind of...
Yes, that is called the fixture mount.
Okay, the fixture. That's what we're using right now?
Yes, so when
Okay.
you place an implant, it comes with it. You use it to place the implant, then you put it back, you always save it, sterilize
Okay,
it, put it
now-
back, and then you can also cut it down, prep it, and use it as a temporary abutment. So
These-
there's 3 ways to use it.
I'd hate to sound like an old person here, but the long screw for a open tray kind of thing, that doesn't come with it. That's an additional cost.
That is So that one that you just used, that's for closed tray impression.
Right.
It comes with it. If you want to do open tray impression, you buy a whole impression close.
Okay.
And it comes with a screw.
Okay, so that wouldn't work with a long screw for that one?
No. So you will use this.
It's just, I would tell you, to do the open tray technique is not any more time consuming, and I feel it's a lot more accurate. I feel uncomfortable with them pushing those things back in the impression, and
No, it
there's
is more, especially if you have multiple units.
well, yes, doing multiple units, yes, even more so,
But then, like I said, you take it, you can cut it down here,
yeah.
prep it, and use it as a temporary buffer.
Oh, okay.
So three ways to use
Okay,
it.
so I can use that to start to develop the emergence profile and the like,
Exactly.
as well as people get a little anxious about not having a tooth for as long as they have
Exactly.
already. And
Then we have these little plastic ones.
That's
Those are
right.
actually nice too.
That's all bad.
Especially if you have, that's a plastic temporary abutment,
There
it
was
can
a
stay in
time I
about
did
480 days.
course
You can
and I
get
was
cut it, prep it, if you put a
dentist.
crown on it, it's, it's not going to show.
so you're in a front
It's
tooth, the
aesthetic,
metal
yeah.
stuff is going to be the green and the
Yeah.
different colors is going to show through.
But this one is, and yeah.
Now,
And I didn't check.
do you offer a course on advanced restorative kind of stuff?
This is, we have restorative 1, restorative 2, yes. This
Because
is comprehensive.
yeah, because
If
what
you buy
comes,
10 implants, you can come to this
I
restorative.
just bought 10 implants.
No, like down the road.
I know. I'll have to buy 10 implants. I've got the 10 from my initial kit I bought from the last class. I've already kind of promised to people that I would
But
do
if you
it.
want to just do tuition and just come,
No, it's just that I would tell you, one of the guys I do implants with works a lot with biomed, and they talked about all in all about how they were going to teach us how to do the fixed removables and stuff like that. And I would tell you, I went through 4 lectures, and pretty much when it came to talk about that, they talked about it for 5 minutes. They said, you do this, you do this, you do this, you do this. Okay, next one here. So,
you know, you're rep.
well, yeah, I would tell you, I'm still working with my rep, and I'm assuming you offer a lot of these classes also in New Jersey, I hope? Okay.
It's all in all.
It's just that because I took the first class with Dr. Downs, I wanted to come out here, as well as my best friend from college lives about 10 miles south, and I figured it was a good combination. I live in Washington, D.C. area. My rep was a gentleman by the name of Max Williams. He's relatively new, he said. He was going to come out here for the cadaver course, he said.
And then the other thing is, you
We
have
have
to make
one,
sure
yeah,
you
we have
don't
one
dead
in
out
Vegas.
on the trays. Remember that?
Yes.
Dead out means you get through the impression tray to the side of the wedge.
So then we have these little short, those are our stock abutments, right?
Yeah.
They're all preppable. But then we have these cute little short ones. If you have, for the posterior.
Right.
Which is nice. And it comes with a little snap cap. So you put it in, if you want to take an impression, picture of the impression, snaps in. You take an impression, it stays in the impression, and then you put the analog inside.
Study models, not to
So that's a
dead out on
different
the
way of
tray.
doing a,
Getting it
closed tray
distorted
impression.
inside the wedge. Yeah.
I didn't see that. Whoever your dentist is not going to be happy about that. But I'll tell you, break it off. I'm sure you can probably find somebody to put an implant in. I just got this impression that you could.
Yeah.
You might know somebody that does
Those
that.
who use the yellow wash, I see better extensions. I see better extensions. And that's important because when Ross makes the abutment, he needs to know where to finish the line too, right? And if, I don't know, if you get, sometimes you get them back and that line's too deep, huh, John? You have to do what? Pull the laser out, or, you got to cut tissue away. That's the only time, boy, you wish you had the seal too, because it just evaporates away that tissue. Everyone's got theirs off. David, you got yours off back there?
I'm supposed to take it off?
Want to take it off?
The patient was supposed to wear those things.
Now, number 30, which is the one that you did the flap on, I want to see, just for practice sakes, they have a 5mm punch or a 4?
Wow.
They have one above.
Mine has a little bubble already.
Okay.
Yeah.
Let's
Oh,
go
we got
to
some
your
gauge.
kit. There should be another punch in there, a 5mm punch. And those of you who are asking, well, how do you know where to find it, you know? You have a general idea where it is. All right? Yeah, it's in the kit that has the implants. You have a general idea where it should be.
Yeah. Okay.
Now, you may have to try to hold down your flap there, but I'm going to see if you guys can.
Yeah, you know
Go
what?
ahead and-
Well, at first he
and
said,
cut
don't
down
use
to
the
it.
light body, and then
Because they don't have any tips.
after I start, well, we have the tip for it, don't we? The yellow ones on board still?
No, but there's no tip. If you did, I can still orientate.
No, I
Even
personally, I
if you
usually
took
like
like,
to have
you know you're
the
going to
light body, I
anesthetize,
pick up the
but you
detail.
can even take a Ariel Pro sound down and you'll find the little screw or the hex head.
Yeah, I usually take a heavy body with a light wash,
Screw.
Yeah.
and,
Of course, the
So you
better
kinda get a
that,
good
just like
idea.
you're thinking, the better that's
It-
captured.
Sometimes
Right.
this works for some it doesn't
Can I get that
because
back in
it
that
depends on that flap. But I just want you to get the sense of pushing down on that and trying to get that off. Go down in there and get off the ceiling cap.
Yep, because the one side is so clear, yeah, with that missing, just that little void there, that would still work.
my God. Okay, I don't know. I don't know. I think we probably should take the green thing on out. Actually, what I'd like to do is spend time with Zimmer reps.
We have to remove this thing for all the wax so we can.
Do we have an Explorer up there?
Back for it, back for it. You got that on back for it. That's all right.
Periodontal, probably.
Normally those sutures won't be there, right? Everything will already be gone and healed up. But just kind of get the idea. It's a twist, 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 twist. Those of you, this is called your cheap laser. Okay, back for it, and then go to your same screw that you fixture screwdriver and take out the ceiling cap. Bill, how many times can they use those things? Yeah, in real
Yeah, on
life.
that lower one, yeah.
One timers. Yes. So don't worry about cleaning it out. Then take your ceiling cap out and see if you can get in your fixture mount, the gold one.
Got a spinner.
Yeah. So yeah, they come in 6 and 7, you said? Up to 8. So you'll probably get a sense that this one might be a little tougher to deal with because
Rubber.
the opening element isn't 6 millimeters. Yeah?
So a little hint is, if you can put that healing cap on there, rather than covering it up, healing collar,
No, we're going to take and put your impression,
it'll make everything easier.
put your gold impression transfer post on there. I want to see if you can twist that down there, because sometimes you're going to run into tissue like this. You've got 5 millimeter opening here. It's going to be tight. So just get an idea. I want you to see, can you take that gold fixture mount and put it in there and twist it and get it to click down and then lock it down? Did you?
Hang on.
All right, good job.
Cut it all the way. You have the periosteum, and it's the hard material to come loose. When in doubt.
And you know, speaking about lasers, you know, CO2 is your best bet. You're going to pay more, yet it's priceless once you start using it, right, Dale?
Here's my
Dale's over here
diode.
going, we don't use it, we use our laser. These are for doctors who can't afford a laser. Someday they will.
Oh, yeah.
Hey Jim,
Yeah.
what's the company that seals the laser?
Oh, it's Lutronics,
Yeah.
Denta 2. Yeah, it's a great laser. You'll use it for everything. Yet, if you need it for peri-implantitis, it's the only one you can actually touch the implant.
How long have you been working with implants?
You can't do a diode. If you have a diode, you can do this.
Did you work much with external hexes at all?
It's pretty heat
This was
sensitive.
the thing that drove me nuts.
Yeah, and heat's
Tissue would
our
grow in.
enemy here.
Try to get the components.
CO2
Try to get
is
things on there,
dehydration.
and the
Got it
tissue
good?
would collapse in between it. And that's when I came very
And then
familiar
again,
with
you
the
would go
tissue
through the
punch
same process of
because,
doing what we just did with the impression
Yeah.
on number 5.
let's see here, I want this is yellow.
Yeah, now, question about how to get the wax out after you took the impression. Take
I
your
want the
Perio
original.
Pro, just keep it tight. In fact, I'll look for mine up here.
And I need a screw.
So, on the wax right there, okay, and you just come in, I come in close to one side here, okay, and just swirl, and out it comes. Then take your screwdriver, come back in here, take it out. Okay, very quickly. And it'll always inspect here, make sure down there you didn't entrap tissue when you lock this down on it, because again, you're going to have a distorted placement. So again, you want that tissue to be cleaned out of there pretty nicely. So going through this exercise on the lower, some of you found, it was a little tougher getting that little screw and everything out of there. Guess what? That's real life. And you're going to have to deal with tissue. Because a lot of times you take that healing cap out, doctors, and the tissue's just going to squeeze in.
Yeah.
Right? You look in there and you go, what happened? There used to be a big hole. If you think you're going to run into that, then have some cotton pledges. So as soon as you take that out, pack the hole. Keep the tissue from collapsing in. Because as soon as it starts collapsing in, some will get soupy, and you're going to be fighting it. And the only way I can deal with that in my hands is with CO2 dehydration. Just get in there and get rid of it. Flare it out, flare it out, flare it out.
Hey Jim,
Yes.
what is the indications for placing healing abutment at time of fixture placement?
So the question is, what's criteria for when to place the healing abutment versus a sealing cap? The sealing cap, David?
Yeah, so something sticking out at time of initial placement.
So the criteria is in my hands, and I think also in Bill and John's, is if you're going to do a punch technique either with the actual punch, scalpel punch here, or with a laser punch, and you've created a tunnel, David, already.
Yeah.
If you then replace that opening with a healing collar, that's fine at that point, because then the gum's going to grow in there. But if you flap, it's difficult to put the healing collar on, because then you have to trim a hole in the flap, and it becomes more of an issue. So a lot of times you put that healing, the sealing cap, the really small flat one that you guys did, you put that one in, and you go over it, and we call it bury it. Then leave that tissue and come back in, David, and do the punch again. It's just a cleaner job. It's a cleaner job.
How about single stage surgery?
How about a what?
Doing a single stage surgery as opposed to 2 stages surgery.
Yeah, well, anytime I can do single stage surgeries, that's what I'm after. So, like in the sites that we're going to do this afternoon here, are we doing punch or are we doing both flaps? 8 will be a punch. Okay. So on 8, if you had that, say a 3-unit bridge there, David,
Yeah.
you took it off, and 8 had a ponic site, really good bone, everything, you can see that ridge. I wouldn't flap that. And here's the reason, if I really know that I've got good criteria there on the bone, is that, and then like on number 5, is that I want to keep the interdental papilla. As soon as I flap that in the anteriors, you're going to blunt your papilla points. And then you're fighting with that. You're going to have to ask Ross to give you long contact points in the prosthesis to hide the black triangle. And it doesn't look that good. So what we found in that whole criteria, that 5 millimeters from the crest of the bone to the contact point, we can maintain the interproximals by not taking them away. So the punch technique works out really well. Okay? Single stage is really great if you can always do that. Because like I said, if we have to disturb it only once or twice, that's really the best. Now, Zimmer does have a single stage implant. Yet, then that means you got to turn that thing right at the right angle, and you better have the length perfect. Because if you dead out and you go, no, I need to go just a little more, you know, to orientate the facial, because that you have to have the facial orientated. I mean, that's the greatest implant you could do, yet it's very technique sensitive. You actually have to drill deeper, right, than the intended length, so that you could twist it. And it's just a matter of luck if you get it in the hole the right way and you twist it, and you know, so it's very tough. It's different. Okay, so let's go ahead now and any questions about this? I mean, is this pretty simple or what? Jeremy? Yeah? Still goofing around? All right. Actually, I'm all done on this. Let's get ready, Bill, then. Great. Okay, let's get ready to go do some more surgery now. Now, I tell you what, when we're doing this number 8, it's very important to watch how he angles things. The worst thing that you can do in this region, like on the lower and perforating the lingual plate, that's a nasty resolution that you have to come up with on that. So he's going to show you about up in here, because the tendency is going to be to want to come in straight at this, and that's not the anatomy there. So really pay attention to this, because he's going to make you do a punch. So you can't flap, you can't see, Alan. If you're too facially, you're going to have a problem with this implant. So,
typically, what Jim said about flapping in the anterior and the papilla, I drew on here what I consider a papilla sparing incision, where I leave the papilla intact and I come in just basically to the width of my implant. And normally, if I don't have an ICAT confirming the topography of the bone, I personally will flap, because I got to see what's going on. The anterior maxilla will fool you a lot. So today, just for ease of what we're going to do with the temper and everything, we're going to do a punch technique. So we're going to consider the fact that there's been a tonic here, and we've done a 3D scan. We've got good bone topography. You can also make, if you want to, you can just make a mid-crestal incision and flap palatal and buckles, just hard to retract. But that's easy to then create your hole for your implant as far as the second stage. But this as far as papilla sparing will work. Now make your extensions way up into the vestibule too. In the cosmetic zone, when I talked about the vents and not sewing the sides or the releasing incisions, in the cosmetic zone I tend to put a stitch in the releasing incisions. I want everything to look the way it looks when I'm done. You don't worry as much about the hydraulic pressure, and you want to get the cosmetics down. All right, so we'll get our 5 millimeter punch. We're going to put a 4.7 implant in here. Now, on your initial assessment of this patient, when you look in here, in the anterior, from cuspid to cuspid, you want to put that implant centered on the cingulum. You'll get fooled by looking at the sizal edge every time. You want to put that implant on the cingulum. The maxilla resorbs up and back. The bone's going to be up and back. All right, so we're going to take our punch. We're going to look at the cingulum. Fortunately, we have the lateral, the central incisor here. We're going to look at that cingulum, and we're going to center our punch on the cingulum. Now, well, here, I'm just noticing that this punch doesn't work very good on this. The teeth are so tight.
Get the long handle one.
That's why I showed you earlier the long handle punch that I use. This is a perfect spot for that. It's nice and narrow. Okay. So let me go to plan B here.
Extract 7 and 9.
Yeah.
You get a better aesthetic result.
3 implants.
Crowns all match.
Just all right, I'm gonna. You can get the. I get all these at Salvin also, or I get them at Ace Surgical. But see the difference in this? How it fits down in there nice. See the length of the handle? How you can tell you're parallel. You can see if you're off a little bit. So I'm going to go right at the cingulum, and I'm going to punch that hole. And then I'm going to send my little hanky skinny little punch down around the room here. Here you go, John. Help some of these guys out. Punch the hole for them.
What does he want us to do? Does he want us to do the punch, or does he want us to do the punch? Okay.
Ask him to show this version is when he placed the, you know what I mean? He told us to line it up with the CL.
Yeah. Yeah, they should be able to. I do know every time I see them talking about this in classes, they're always placing it, you know, off center on the palate with an angle back. Because they show you pictures of the implants in there from years ago, and the screw is coming out of the facial edge, and then we just ground it off and put some composite over it.
I've been told before, they don't think that it's always easy to put the implants in the that's the hardest one because you got to deal with the cosmetics.
Right.
Because if you put it in too far facial or not deep enough, you can see metal sticking out of the gum.
Yeah.
Okay, sure. There you go. He's tilting it.
It's going to be in the cabinet in the metal tray. It's
Make sure you bring it back.
yeah.
You can use your blade to do it by hand too if you want. It just takes a little longer.
Okay,
Because yeah, you
well,
usually want to see exactly. Do you want to come up and take a look? Yeah.
yeah, let me do that too.
And trim it out.
Right up against the screw.
which is what this is for. Then, you might want to set it up just to get started, maybe modify it down to the third or even the second based off of and then you
John, give me a heads up whenever we've got the hole punched.
Probably right through there. And then they can use this to fill this in for temporary wait in place, maybe block that out. Or, yeah, as soon as you place this over, you can
Back here needing all pipe.
that's good. That's an exercise. Technically, this isn't like that if it's all up, but it'll die as a free out. This is in the pedal tray. Exactly. Yeah. So pretty much redo it and see if we can forward them back in.
Now, when I told you earlier about that little needle-shaped burr that I gave you the info on, in the anterior maxilla and the anterior mandible, I use that exclusively as my first burr because it gives you more room for error. Okay? You want to give yourself as much cushion as you can. That little needle burr will give you a lot of room. You put it in, you drill the first hole. Now we're going to use the brass burr first, but you could use the little needle burr first. Take it off and look at the angle. Take it right off the handpiece and leave it in there. It gives you a great angle first. So what we're going to do, remember the maxilla up and back. So I keep my finger on the anterior maxilla. This is what John was trying to tell you earlier. You'll feel the burr moving the bone before you feel the burr penetrate. If you feel the burr, if you look in the monitor, and I've got my finger here, I use my thumb or whatever, if you feel the burr getting close, then back out and change your angulation. Don't perp to the buckle. You're not going to perp to the palatal necessarily, but you're more likely to perp to the buckle. So we'll go in, we'll center our drill on the hole. We're centered between the lateral incisor and the central incisor. Notice I'm keeping going more toward the palatal. You look like you're drilling right into the cingulum of the tooth, and that's what we're doing, exactly what we're doing. We're going to put that hole through the cingulum. Go to your second burr and then stop. So use the brass burr and then the 2.3, use the 2.3 long. We're putting in a 4.7 by 13 implant, but don't go all the way to 13 yet. Just go down like an 8 to 10 and stop. Now I've put the skinny part of my little parallel pin in there, and I can tell already I'm just a hair off. So I'm going to change my angulation, but it's not too late. Angulation mesial distal is not a problem. It's that angulation to the buckle that gets you to be a problem. So we're putting in a purple implant. You look at the lines on there. Our next drill we're going to use is going to be a 3-4. I've got my angulation. I'm going to correct it on the 3-4. I'm going to go a little deeper here now. Again, next step, I'll use my parallel pin again. This time I'll use the bigger side. I need to correct my angulation. All right, now I've got my angulation corrected. I've got it centered mesial distal, and I've got it directly in the cingulum. I drilled the depth. The next burr we go to is the 3.8, because we're doing purple. The purple dotted one is the next one. So, as Jim spoke earlier, you've got approximately 2 millimeters of gingiva. So you're actually taking this down to about 15 millimeters on the drill if you're looking just at the gingival line. Check your angulation every time. All right, when both people have their hole drilled, let me know. We'll go to the next step.
Which tooth number is it? He's going to do it on number 8. Which is a 4 or 5. But in the little kids, tooth number 8. It didn't say it's yeah. This is supposed to be green or purple. I think it's.
I'm going to over-drill the leaf just a hair in the anterior. I want my metal all the way down the bone. I don't want any metal above bone.
Yeah, I think, kind of like what he said, what we're looking for is, if you imagine this, the front plane, a lot of times it's so easy to figure out. That'll be nice and easy to restore. No, I think it's good. I mean, that's the only hard to tell.
You're going to err to the palatal.
You're always dealing with the vestibule here. Yeah, so it's always a little hard to tell. Because obviously, if you were to just follow the bone, it's kind of more at this angle. So that's why you move it back, and then that allows you to have a correct angle.
So it should be this way or this way?
No, I think the angulation is good on it. Because the tendency, is to follow the bone, which would be more like this angle, But then that sticks out through the buccal plate, the facial. So the key is like where you started, then you have good angulation. Yeah. I think angulation is good. I think, maybe ideally it would be just ever so, just barely.
That's happening for sure.
It's on the.
I mean, not everybody, but we'll do our own thing.
Because you want.
I've got a friend in Delmar I'm going to meet for dinner. I'm sorry.
Right there,
Thanks a lot.
You know what? I've lived with this man for 2 years. He got me into dental school.
Seriously. Bring him along.
His wife and his 2 children.
Yeah.
Doctor, are you coming to dinner tonight? Seriously.
Where was it?
Frescoes. Here?
Okay, where is the rigging?
Oh, we do assign this one?
If you change your mind, just go.
Okay, thanks. 19. I scratched myself with
Light?
bone graft. So I sectioned it off at 21. Pulled out 19, so I had 19 or 20.
All right,
First I got 6 millimeter and 19.
somebody asked me, somebody blown out someplace, and they asked me, what do you do? You back out, you graft it, put a collar plug over it, seal it, and let it heal, and come back and do it later.
Does the patient?
Tell the patient going in that they know that's going to happen, maybe.
Take the implant out, you blow it out.
I'm very paranoid about my teeth. What were you going to say?
Tell you what I think about you. Have you heard that? Let's talk about me.
There's no harm in doing this, but it's invasive. I set up 4.7, so which is so we're following where the lines are.
So after I use this and so I told you this one.
Well, that would be for software. So if the bone is really soft, you do this
Purple dot.
So you go to the purple.
So think of the dot, it's kind of like
Oh, this one. Oh, because it's shorter.
No, you go the long one. You see the purple dots?
Yes.
So that's next, and then that is next.
Okay.
Anything with purple on it, just go in sequence.
Okay. So
otherwise we go to the final purpose.
Okay, that's a little loose, we'll just turn it over like this.
Yeah, I mean,
No, that looks really nice. Yes, really, very nice.
Hey, Bill, could you give me a hand here for a second? I'm wavering a little bit to the distal
You
here.
are indeed.
And
So, yeah, so correct it now.
how should I correct it now? I mean,
Put the smallest burr back on.
the gold one or the,
No, the pot, this one right here, this one right here. Put that back on. And now just go through your initial cortical hold and just straighten it out.
okay.
Yeah, that, but I was thinking, okay, let me. We're not gonna use any next week.
Any what?
Can't use any.
There you go, there you go, there you go.
Yeah, I'll get something new. And then I have this is I haven't done this in a while. It's not ideal.
How am I in terms of far enough palatal? Is that?
You're not quite there, but we'll fix that on the next one. All right, see, that straightened it up very nice, very nice. Now, we want the screw to come out through the cingulum, not through the incisal edge.
Right.
So now the next,
Facial.
we're going to go just a little bit this way next time. No, we're going to the purple one.
Oh. We jump over that one?
Yep.
Okay. You know, the endodontist tell you shouldn't skip any files. Okay, so I want to take this more.
Perfect.
getting more towards that thing, you know. Should I try to take it a little bit more?
Well, no, I think you're
Not
in
bad.
good shape there.
Okay.
Just getting a little too close to the central, see that?
Okay.
So just straighten it just a hair with an expert.
Purple.
So what happened?
Are we supposed to put the implant in as well?
Well, I don't know. It's up at this point. Yeah, it's up to that point. Wait a little bit. So, David, after this part, you just take this back out. And
You take it back out, put your healing thing in, send
this and
that.
the other one. That and this one in there.
No. That's
Just that one?
just that one.
So what's this? What's this other big one for?
That's you know, sometimes you have situations where you're going to be pulling multiple ones and the like, as well as sometimes you get into things with the bar dentures and all that kind of stuff. That's the kind of thing I want to sit down with my rep and go over every little thing in the catalog, because it helps to know what's available. Because sometimes things are available to help you, and you don't even know about them.
So just send this to the lab.
Yep. I mean, I talked with Ross, and he says, you know, they pop it right on in, and they feel pretty confident if you got a halfway decent impression that they get it in the right place.
Yeah.
Which is what's nice on this as opposed to the other ones, of course, you know, if you're not paying extra for this, that transfer. You know, the transfer is part of your implant fee. Whereas, like with 3i and the like, that's about $35 to $40.
Yeah, exactly. They asked me to purchase this and this thing.
You know, I think, you know, it's just a matter of having the right parts. And I would tell you, that's an advantage and disadvantage of implant stuff is years ago there wasn't any parts. Now we got 10 jillion parts, you know, and it's like, okay, you get gridlock. Well, I'm going to put this implant in.
Oh, there he's putting it in now.
Grab the right tool. This is a purple. Double sealed, 4x7 by 13 millimeter long implant. Keep it sterile. Assistant grabs it, pops that, put on a driver.
When you put your implant in, if you haven't already put it in, when you put it in, if you use the hand driver, it works pretty nice. You get to see your angle, it's right up front. If you just put your implant into the hand driver and put it in. Now if you look at that purple carrier, all the carriers on these dimmers,
Like this, right?
Yep.
But it's not supposed
Actually,
to be loose. Because that's what
So you're tightening this
yeah,
down.
what I did with the carrier, I just put it in my fingers at first because
Top
I
of
didn't have
that
to worry
taper
about
there's
flopping off
2
your
millimeters. So you want to make
thing.
sure that that
So one of these
taper
right here?
sub-gingival.
Yeah, one of the drivers there on the left side, I think these 3 right here are the ones. I think you might want to grab the longer one too because it's a central.
Take it all the way to the bottom.
We'll take some of those, these tubes, repair them
Okay, we get down here and we take off the little hoo-hickey.
and hopefully maybe a fourth of
You'll get an idea, you can try it in the patient's mouth, and let's say, just to get started. And then, so you just stick on this application.
Just something like that.
Set that aside.
Somebody asked me,
You know what?
somebody asked me about when to temporize or when to just bury it. And how many Newton centimeters. You can put your torque wrench on it and check it if you want. But if you're using the hand wrench, actually, you can feel the pressure. If it takes a little pressure to get it in there, you're fine to temporize it. When you're in that white belt, as Jim says, be careful putting temporaries on immediates on any of these. You know, in the beginning, kind of bury everything, get your feel for it, get your success rate up. The key to this is getting your confidence up, your patient's confidence up, and your high success rate. And then as you proceed and mature in your surgical skills, you'll know the feel of the implant. You put it in. If you want to put a torque wrench on it, get 35, 50 Newton centimeters. Make sure you have it before you put a temporary on. That's a good way to do it.
So that one's
I can feel it. I can feel it with my hand.
It's from here?
And that's why I try to teach you to do all this with your hands and not with motorized.
Which one? Well, which one?
So if
This
you
way.
put it in
These
there,
are the little ones, the little
very
tiny
touch
screws that are
experience.
deep down
Don't put
inside.
temporary on, just bury
And
it.
then these
Sounds
3
good.
here are direct drivers. You know, you can go, you take off the purple thing with the little tiny screwdriver, and then you've got a driver, a square driver in there that you drive it down that last 2-3 millimeters. Yeah, there's a lot of tools. It's like going to Home Depot and going into the wrench section.
I get this in here with this thing, right? To get a hand
Yeah, you can. Yeah, this is the long version of it. Here's the short version. Yeah, it goes, so this might be a little bit more practical. Sometimes, the long one gets. Obviously,
Leave the purple carrier on the implant because we're going to make an impression for temporary. We're going to do an immediate temporary.
yes, like that.
So leave the purple carrier on.
I thought we were supposed to torque it down with taking it off.
So what's this one for and what's this one?
These ones over here.
Put it back on.
These are for the 6 millimeter implant. If you take off the transfer mount with gold coping, it has a larger text. So that's what these are for. 99% of the time it's going to be one. Right. Yep. These are prosthetic. So this last row are all a 1.2 text or 0.50 driver.
Yeah,
So we got a long one here.
Dr. Downshore was he's gonna work on some sort of,
Kind of are the
if he
same tool,
wants to
but they
do
can
it
go in
I will,
the, in the ratchet if you need.
yeah, he wants to show up and have me next to him, answer any questions.
Yeah, the prosthetic stuff. Yeah, exactly. And actually, let me.
Yeah, we're good. I booked a flight pretty late, so I was able to, my flight was like at 6:30, so I was
So
able
this,
to stay
yeah,
there.
I think that the certificate in 3 ways. It drills the osteotomy, which is kind of this section up here. Yeah, you drills and then the tube placement of the implant.
That was like right around there, I was just
drill
filling
right
time
here.
until I could have went there, but it's
Mostly
it
going to
worked
be
out,
these.
I mean, I
And
got
thirdly,
there
taking stuff on and off of
He's
the
already going to the surgery, but I set it up for him, I started him, and during the breaks of the surgery, he came and, I mean, yeah, he got a lot of money. Yeah, I was there for 3 hours. get quite a bit of that. So he seems pretty comfortable with it. So yeah, it's good.
You guys worth coming out there yet?
Okay. Now, be careful now. On these mannequins, in a human, you take your purple to the dotted line, and most of the time you're going to be able to put that implant in just in that soft bone, just by going to the fur with the dotted line, the 3.8 fur.
Yeah.
I generally will take my 4.4 fur just through the cortex. I won't go any deeper, but just through the cortex so that implant starts easy, and then you can take it on up. So in nice soft bone, you stop your drilling at that dotted line, but in these mannequins, the bone's consistent pretty much throughout, so I always go to the bigger fur. In a human, you can stop at the dotted, just open the cortex with the 4.4 and stop. Because it would get a little hard. She was having a hard time putting hers in. The reason is she didn't get her hole expanded quite big enough. If you put that implant in and it's hard to put in, back it out, widen your hole a little bit, and then go back in.
Yeah, I know exactly. That's what to do.
Just do it the same way every time. I don't care how you do it. If you want the flat piece of this or anything, however you do it, you do it the same way every time. You'll do that when I get back to your lab. Okay. Just do, yeah. I just didn't have it put on the flat side of the facial every time. Just so in my own head, I know I've done that. Mine could just wear the palatal, but a better to air to the palatal. I was using the device, but it's nice. Switched over to why?
So this thing should be in bed, right?
Yeah. I peel the gum back. Let me show you, because I had a question about that too. I think the 2 millimeter collar should be above the gum line. Yeah. Well, the 2 millimeter collar should be all the way down to the bone level.
But like this part here.
Well, that part there, depending on this, you know what?
Yeah.
Occasionally, you're going to have your lab either do a zirconium abutment or something like that, because if it's real close, you're going to have issues with the titanium abutment and stuff like that, because it's your collar, your gingiva sometimes can be very thin.
Mm-hmm, yeah. So I think this one should be like right at the gum line, right?
Well, that's, yeah.
This is lower. This one should be down lower than this one should go down to.
Well, let me ask somebody. You're not a Zimmer guy, are you?
I'm not, I'm sorry.
Who do you represent?
Piezo Surgery. Justin.
Piezo Surgery.
Good to meet you, bro.
Is this the one that when they do neurosurgery, that they go in there and peel away things from your spinal cord, not cause you paralysis?
Yes. Well, this particular one's for oral surgery, but we make a device that does that, yes.
One of my friends is periodontalist. It's better to blow it out. You say the egg thing where they go, you can peel the thing and it doesn't even affect any of the membranes.
You can peel the whole thing. As long as you're careful, you can pull the whole thing off to where it's just a membrane. It's pretty cool. But you can go in somebody's mouth and bounce it off the nerve. It's pretty cool. I mean, I'm used to it at this point, but you know, usually when guys when they first see it, they're like, "Holy cow!"
So is that an alternative to? Does it also does saw kind of stuff? You want to take block bone out and the like?
You can do anything with it other than lay down implants with it. I mean, sinus lifts, extractions, rid split. It's meant to be kind of like it's like a Swiss Army knife. It's kind of meant to be versatile.
It's all through ultrasonic.
Yeah, ultrasonic micro vibrations. It only vibrates the length of a human hair, so that's why it's like a those saws that will cut metal but won't cut wood.
Right.
The cut is so small that it actually cuts dense material and not less dense material.
I've seen those on TV. It's amazing. Put the hot dog in there, and that thing just boom. Doesn't even cut the hot dog.
Yeah.
It's just.
Same concept.
And I will admit to you, that's more amazing than the piezo thing. But it's
essentially
you're also cutting.
But I mean, when I do the demo, and I take a bone, you feel the bone is thick, and I slice right through it like it's butter, and then I take it up against my hand and go like this. People are just like, "Holy cow!" If they haven't seen it before, if they've seen it before, you know. It's like everything. The thing about this business is it's like everything's shocking the first time you see it. You remember the first time I saw an extraction, I saw a woman get all of her teeth pulled out, and I was like, it was like jarring every single one. Now it's after like the third one, I'm just used to it. But it's funny. It's always funny seeing somebody's reaction. I was trying to show a buddy of mine a rid split on YouTube, and like I'm not thinking that like he was gonna. I'm used to it. So he was just like, oh my god, it's funny.
Do you work with just the implant people, or do you work with other oral surgeons and periodontists?
Oh yeah, all of the above.
Do they use that kind of thing? Do they eschew more hand use something like that? Let's say if they're doing facial reconstruction.
Yeah, we I don't do a lot. I have some guys that do those. That's not as common, but yeah, we have some guys do it. I had a guy that had. You're talking about like if somebody's like we had a guy that he got in a car accident and the first doctor who worked on him had messed up somehow to where he had this massive, I guess, overbite or underbite where his mandible and maxilla, the teeth didn't even touch. So we had a guy come in with a piezo and
saw through the mandible and bring it forward.
Exactly.
I
mean that's not that common though, but
they get trained a lot of times on strikers and stuff like that. But it's because they're used to that. It's more difficult to change that. Like anything, even these electric hand pieces here, it's a change from what I trained on when I was in uni for years and years and years. So you got to get open-minded to changing tools. But you know what? We need to grab a Zimmer rep. We need to clear that up. They should make them wear like red scrubs, the safety patrol up and out. We got a question.
I can answer.
Let's hope so too. Because this is a little bit more technical than the last question. Okay, there's a nice collar around that implant that is not machined or anything like that. Super crestal of the bone, or do we want to bury that more?
That's a great question. Let me grab.
Okay.
Sorry. A little too technical for my knowledge.
Well, earlier I kind of asked another guy, what's his name, Dr. Black, and he said, you can leave it that way, but sometimes in this area it's a little bit more of an aesthetic issue because you got metal showing.
To bring the only down to the gum line.
Right, and
the thing you're talking about, 2 days ago, this lady like in Holland, she broke up with her boyfriend.
I pulled out all the teeth. I saw that.
No problem.
Yeah, you know what? That's why you should never have a woman dentist as your partner. Okay, we're gonna. Did you hear about the woman dentist in Holland that got ticked off with her boyfriend and pulled out all his teeth under anesthetic, and he woke up without any teeth? So his new girlfriend broke up with him because he doesn't have any teeth anymore. And it's like a massive loss there.
That's a big deal, though.
It's
I woke up without teeth.
Now you know what? I know plenty of good implant implant surgeons here. It wouldn't freak me out, you know.
Bring him in, yeah.
It's like my staff, I always tell them, I say, how much would I have to give you to extract one of your front teeth and put in an implant and replace it, you know? And no. I would find the best implant surgeon in the world. It wouldn't give me that. $1 million. That's that.
I mean, yeah, she's definitely going to pay for it, so.
Give me 10 grand. Somebody can do that. I don't have any problem. I'm a dentist. Okay, the collar here of the implant, it's the non-machine portion.
Correct.
On an upper anterior tooth, do we want to bury that entire implant to the crest of the bone?
Yes.
Okay, so
Yes.
it's not as important probably on a posterior
Exactly.
one, but up here we've got metal and thin
yes,
gingiva.
yes. And what you might want to do is, using the Zimmer system, we have a roughened surface all the way to the top with micro threads. If that's what you know, in the anterior, I have a lot of guys who switched over to that because they feel more comfortable with a roughened surface.
Right.
However, I mean, we have over 10 years of studies with this, and it works fine.
Right.
We've got other guys who are like, you know what, Sean, it works fine. I just put the machine collar where I want it, crestally, or sometimes in the posterior supra, just because you get, now you don't have an implant above the junction. You got it off the bone.
But this, we should take it further. But if we have issues, if you got somebody's got some thick gingiva and stuff like that, that's not good. We're worrying about gingival show through that implant very much.
Correct.
Okay. Where's Lori? And like I think Dr. Black was saying, or Dr. Downs was saying back here, I got close. It's just a little red light there, although I'm 100% certain that's in a good place. But he said you can back it up and so it sits up maybe a millimeter super crestally so that you can stay away from the nerve.
Yeah, definitely.
But here, that would be a problem there, aesthetically probably.
Yeah, you know what? If they had, thick tissue, like you said, you could be okay. But if there was recession,
And also
right,
in
10
the,
years down the road, then they're going to be like,
your blue kit,
But so I would definitely go crest.
in the little additional number 8, if you open it up to number 8,
And one thing, what I like to do is I always recommend is
open the inside up, and there should
fixture
be
transfer mount on.
Yeah, I did.
And you can see, you can visually see.
temporary
Put
abutment,
it back on
plastic.
because he wanted us to have it on.
Oh, because I think we're going to make an attempt to.
Yeah.
little-
And
So that blue handle-looking thing called the
That's
abutment
way too
holder
high.
is in the cabinet
Yeah,
in the
that
upper
wasn't
left in a metal tray.
Yeah, I guess.
We haven't used the metal tray yet, so we'll have to pull that out.
You might not bury that. You might.
It's best, and that's why if you do a flap, it's the best way because you can see everything.
Yeah, I would tell you. Yes, I.
One of these guys.
What?
What you? Oh, yeah. That one might be too short.
Yeah, there's the longer one. I had it out. Here it is.
So we and just so you know, we've got an implant ESV now with roughened all the way to the top. And we also have one that has a 0.5 millimeter machine collar.
Okay.
Where this one is a 1 millimeter. So
Let's go back to your restorative
I'm not saying one is
model
better than the other. It's just different options.
Yet I do want to make a comment about what I
So
saw
that is what we're looking for.
Exactly.
Okay.
on the floor.
Thanks. I'll put this back on to keep everybody happy.
When you're placing this implant, you got to remember about the anatomy. It's really diving in. Okay, if we turn it to the side, you can see the dive in here, right here. So when you first initially start out with your osteotomy drill, you tip to the facial to break through. But as you get about no more than 6 to 8 millimeters, then you got to start pulling it towards the lingual, and that's the idea of cheating it to the lingual, so that when you cheat it to the lingual here, you end up even with the incisal edges, which just puts you just right there in the cingulum area. What I'm seeing is too many of you out here, and so we had perforations. Those that I could help, I showed you how you could re-angle, go back in and restart a new hole, and correct that and get it back here, but then you'll have to deal with that perforation. That's, to me, an easier perforation to deal with than on the facial. So I think we got you too lingual on this, because I saw a lot of people just going straight in and didn't, you were already with the incisal edge, but your angle here just took you right out the lingual. So you want to start in that direction, but then you have to start uprighting it as you go in to go down. Because when you put your abutments on, you can see you may be that's pretty good right there, where you're right with that incisal edge. So this is the temporary abutment. So say we've got good stability, everything looks good, we can go ahead and do that. You can see the markings there from the bottom. 1, 2. We'll start at the 2 mark. 3, you can see you might be a little more facial. So you hold that off. Take the abutment, the analog abutment out of your kit. That's what it looks like. And that fits into this blue abutment holder. That's kind of nice to have, because now you can just make everything on here. It's got a replica of what's in the mouth. So snap this on, and you should have a long screw. Put that on. These actually take no time at all to do. They turn out pretty nice. Okay, so that's what you got, and you can take, I'm going to use the hand piece over here, but you all have hand pieces, and you have a blue kit here. You've got a blue kit here that you can use. The idea here isn't to like cut through the screw, we just want you to cut to the screw, right? So I'll grab mine here. Something different here. You can use a disc if you want. I use usually a diamond.
Analog. Where's the analog?
Start above the second line. Not right in between the second line. Start above it. You'll just kind of bounce it off that screw. Don't cut through the screw.
Yeah, you can cut it down where there's Yes.
And the excess should just twist off. Okay? So, cut it.
I'm very high maintenance.
Go ahead, take this off.
He's prepping the temporary Buttman extra oil, but I don't see that little holder.
In your box, your case 1 box, inside here,
You got
should
the
be a
hook it to the
little
implant
screw,
analog.
and looks like there's one in number 5 down here.
You know what?
Like this?
Yeah, you got the screw? It's one of those ones that are.
Okay.
We're supposed to cut it down to.
Now you can refine it, but let's just make sure.
What screw do we use? The long one, the short?
Oh, no, the short one. Pretty certain because he was talking about not hitting the screw.
That on the side.
Cut it down, prep it for a PFM crown or a full porcelain crown or something.
Which one? This part?
Yeah, that part, the plastic. The other part is essentially the implant analog. But I wish I knew what
And when you get it, you can look at your monitor, put that cut piece back in there. And then we're going to look for your shell. Now, if the tooth has already been there and you're taking it out today, you can take a polyvinyl impression of that and use the contours of that. Just fill it with your Luxatemp. We'll go ahead and turn that down on there, and then put
Wow, you cut that down a lot, huh?
this isn't, okay, like that. Now remember what I said, you have to let the patients know that this isn't going to be exact to their mouth, because we don't want them touching it, but we're going to get pretty darn close. Pre-frame them. And
That's a
we'll
good
take
question.
the Lexicamp that everyone
Who's
has.
that blue thing he's talking about?
Oh.
Or maybe here?
How's everyone at? Where you at? Getting that pulled up. Then get that little screw and just put it inside there. Yeah, clean that up.
Wrench. Lab burrs.
Yep.
Suction tip. There is a burr.
You got it? Good.
Oh, yeah, I found it. Let's check the other, the one in the corner.
Now wait before you, the top of that screw hole, you have to